Okay. The good news, the presenter are giving us another 30 minutes before they finish and come and join us. So I'll stop as soon as they come here. So let's go to captopril. Captopril, this patient was given captopril 25 milligram 3 times a day. I mean, fine, captopril is a good drug. Old drug, still used, but it's a short-acting drug. Most of us here, we cannot finish a dose of 5 days. This is a lifetime treatment. So should we keep our patient on a tedious drug while there are many other long-acting? So here, I will look at it that way. Now, let's go, what will be my second step? I'm okay with carvedilol, but the catch with carvedilol is an alpha reductase inhibitor. Do we have enough nursing staff kuangalia kwamba the blood pressure is normal, because it affects your blood pressure? So there's a catch with carvedilol. It's an excellent drug, is accepted beta blocker in heart failure, but we always have to remember our backup. The statin, I'm okay with it. The guideline says the target should be below 70 milligram deciliter. But back to the guideline again, if the symptoms are not improving, we are recommended to use an MR antagonist, which are spironolactone and others. But what I wish every one of us to look at this slide properly. These are the common ACE inhibitor we are using, from captopril, enalapril, lisinopril, ramipril, and tramadol. Now look at the starting dose. My dear colleagues, it's written starting dose, but look at our patients. We are all stuck with the starting dose, and then we say mgonjwa wangu aendelee vizuri. Ataendelea vizuri namna gani? We are all in the middle column. Now let's look, what is the target dose? Don't answer me. How many of you have given captopril 150 milligram a day? Because the recommended dose is 50 TDS. Enalapril is 20 milligram TDS. Lisinopril up to 35 milligram once a day. So this is where our problem starts. We are starting with the starting dose, and we end with the starting dose. Now, I'll show you this study. Don't feel bad. It's not only you, but let's look on this study. It looked on the gaps in the dose which follow guideline-directed medical therapy. It was a huge randomized trial. It's called CHAMP Heart Failure Registry. The color red, it tells you more than 50% of the patients didn't receive the required dose. The gray is between 50 and below 100. And the 100, the blue is 100%. Now let's look. Let's look on the first circle. The ones who are supposed to use ACE inhibitor and beta blocker, it's a disaster. More than 50%, they don't get the required dose. And you can tell the same to the other medications which are supposed to be. So please, among other things which you'll take home today, let's take our patient to the targeted dose which are guided by the guideline. I almost forgot my patient, but let's go back to my patient. So the guideline told me that if the symptoms are still there, I can add an MRA antagonist. So I've added, and now please take note, as I change the color, this will be my prescription for this patient to the end. So I put my patient on, I add spironolactone, 25 or 50 milligram once daily, and I titrate as I control my pressure. I'll put my diuretic because the patient is weight. We have discussed about the paradigm, so I'll skip this. So what did the guideline tell us? Substitute an AC inhibitor to sacubitril valsartan. Sasa the catch here iko hivi madaktari. Before you start your sacubitril valsartan, you need 36 hours of washout. So you stop your AC inhibitor, then you introduce your sacubitril valsartan. Another catch, please start with the lowest dose, which is 49-51. 49 being sacubitril and 51 being valsartan. So I have added something there. And you have my spironolactone and torsemide. What does the guideline say? If the symptoms continue, I can introduce ivabradine. As I know, all of us, sometimes we get pressure from pharmaceutical companies, but the catch about ivabradine, you have to take your pass rate. The cutoff, the pass rate should not be below 70. So once you see the symptoms are there, please introduce cover. Now let me go back to my prescription. So I have my sacubitril. If you recall my few slides back, I was concerned about carvedilol because of the blood pressure if we don't have a good nursing care. So what we do normally, we put a bisoprolol. It doesn't affect very much your blood pressure, but it will control your rate. So I switch from carvedilol, I go to bisoprolol, which is a once daily, so my compliance also will be good. My heart rate is above 70, I will add ivabradine. So what happens? I've done everything. Now I consider what should I do next. Next, madaktari naomba tukumbushane wote, heart failure management has really changed in recent years. So I can think of putting an ICD. We put ICDs at our cath labs, not routinely, but 2, 3, up to 5 ICDs sometimes in a month. So, but what is the indication of ICD? Your patient is symptomatic, New York Heart Classification 2-3. Your left ventricular ejection fraction is 35 or below, and your patient has been on maximum treatment for 3 months. So please, it's not that mgonjwa amekuja sasa hivi una propose awekewe ICD. Na napoongelea maximum on the right doses. I showed earlier, nafikiri mmeona kule the maximum doses are which. So let's go back to my prescription. I'm still my last step, which is step 4, adjusting my prescription. So now I have sacubitril valsartan, I have my beta blocker bisoprolol, I have my MRI antagonist spironolactone, I have my torsemide diuretic, I have my aspirin, and I have my statin 40 milligram with a target of 70. And now I've considered my patient, I've done everything. I'll put an ICD if the symptoms are still there, and I've followed the guideline how it said. So what is my full prescription now for my patient? Everything which I've said. Now the last 2 bulletins are very crucial in management of heart failure. I will assess my patient for comorbidities, and here which comorbidities which are dangerous is diabetes, which will need SGLT2, which is DAPA, I know all of us are using nowadays. Sasa wagonjwa wetu wenye heart failure, please let's look on hemoglobin. Kwa sababu if your full blood picture indicates there's iron deficiency, naomba tusitoe hemato mix tunatoa ile. Please, this patient respond only on injectable iron, and this is the appropriate thing to do. Now the good thing about this is not only we have read from the literature for others, we have done our own study here. with our principal secretary, Professor Makubi, when he was doing his PhD here at our place. We had patients who were in heart failure, and we used iron, and the symptoms improved a lot. And you can Google for the publication, which we did about 2 years ago. The other thing which is very important, we have to control weight, smoking, as I said earlier, and exercise. Just to wind up, or to conclude, heart failure, again, is not stable. Please, let's try to stick on evidence-based data, on current guidelines, regular intervals of following our patients, because once they disappear the day they come in, really they are on end stage, so we have to make a regular follow-up. We have to check on our comorbidities, and the lifestyle modification is very simple, very straightforward. Maybe this I'll give you as a bonus. There are new drugs which are coming out for treatment of heart failure. Some of them have not reached our side of the world, but let me share with you a few which we'll see very soon, because they're already used in the US and Europe. All of us, we know the guidelines talks about ANI, SGLT2 inhibitors, DAPA and EPA, which are here. But there are two drugs which have not reached our end. I know South Africa has started to use the second one. There is a selective cardiac myosin activator. It's called omecamtiv. This is a new drug. It has got an FDA approval. And there's another one which is a soluble GS activator. It's called Verisuat. I'm not sure if NHIF will ever allow it, because it's extremely expensive, but now they use it for the treatment of stage C of heart failure with. So these are the new drugs, and it's always good to know what our colleagues are doing up there so we can catch up. And I'm sure the two presenters from the US, we can ask them, and they will share the experience because they've already started using it. So for the DAPA, this is a novel. Actually, it started as a diabetic drug, is an anti-diabetic agent, but during analysis or follow-up of the patient, it was seen that it's improving the renal function, cardiac function, so it's a multi-system benefiter, and that's why now we have started to use it on our patient. Its fundamental, or how it works, mode of action is to block reabsorption of the filtered glucose on the proximal renal tubule, where when you give your patient, expect to get glycosuria. Don't get very excited, because this is how it was intended to reduce the sugar in the patient. Then simultaneously enhance natriuresis, which is, all of us know, is a co-transporter with glucose. Thus natriuresis in turn cause osmotic diuresis, so you have a combination just in one line. How DAPA works, you have your glycosuria, natriuresis and diuresis, ambayo in a lead. This is how it led to a lot of non-glycemic effects in our body, including to reduce your systolic pressure, arterial stiffness, volume of blood, and body weight. Which are just a few studies which I don't have to go through, but this was the question which I asked you earlier, and I think most of you maybe were not sure. So the correct answer is D, according to the latest guideline, but because we don't have it in our country, even if your answer me is A, If I'm marking your paper, I'll give you the marks. So let me stop here because mimi niko napiga debe tu. The presenters are here. So thank you very much for listening, and I hope maybe you might have gained one or two things. For those who is repetition in your ears, please, it's always good to hear things over and over. It will help you. Mazen, so if you
we are just loading our presentations for the CME, and just give us some few minutes. Yep. Good evening, everyone. So let me take this opportunity to welcome you all for the CME at Jakaya Kikwete Cardiac Institute, and we are glad to have visitors from US, Madaktari Africa, a team who has been here since Sunday, and we've been spending time with them throughout the day for procedures, and they've just come from the procedure. So I would like to welcome the first presenter, who is Dr. Mazen Al-Baghdadi. He is an interventional cardiologist, and he's with us for past 4 or 5 years and helping JKCI to improve interventional cardiology, and we are going to other stage. He has attended medical school at University of Iowa, and this is residence in general cardiology in Northwestern University of Chicago. Before obtaining training in coronary artery disease and vascular intervention, he was at Massachusetts General Hospital and Howard Medical School, and then went to obtain adult congenital structure interventional in Toronto last year. Due to COVID, he couldn't visit us for the past 2 years, but now finally we have him here. So Mazen, we welcome you on board at JKCI once again, and thank you for assisting always, and welcome for your presentation.
Good evening. Apologies for the delay. Thank you for the opportunity. It's a pleasure to be back. Thanks to Dr. Janabi and Kuzema for the introduction. I'm going to try to go through some of these slides a little bit quickly because I'm a little behind. I do appreciate your attendance and excited to chat with you. So, disclosures: I'm an employee currently of Edwards Life Sciences. I'll not be disclosing any relevant products. Just a brief outline. We'll be talking about acute coronary syndromes. Start by just saying what is an acute coronary syndrome. Briefly touch on the pathophysiologic mechanisms of ACS, and understand what are the significant consequences of an acute coronary syndrome. Why do we need to be able to identify acute coronary syndromes? Why do we need to treat them? What are really the dire consequences we're trying to avoid? And is it really a problem in sub-Saharan Africa? This is an important question that I think we should dive into a little bit further. And then we'll talk about what is contemporary reperfusion strategies in ACS. I'll go through this a little bit briefly because I think what we really want to get to is understanding systems of care and how we can integrate various hospital systems, processes, different physicians of different specialties to improve outcomes for our patients who experience acute coronary syndromes. And that will dovetail with the topic essentially of what are the challenges to delivery of ACS care in low and middle income countries. So acute coronary syndromes represent a clinical spectrum of acute coronary artery disease that includes unstable angina, acute myocardial infarction. There's sort of two flavors of acute myocardial infarction, or MI. First flavor is ST elevation myocardial infarction, referred to as Stemi. The other type is called a non-Stemi, or a non-ST elevation MI, and we'll talk about what distinguishes those briefly in a moment. There's also sudden coronary death, which is unfortunately one of the most common manifestations of an acute coronary syndrome. The most common cause of an acute coronary syndrome is disruption of an atherosclerotic plaque in your coronary artery, or the artery that supplies blood to your heart. ACS, acute coronary syndrome, is a common cardiac emergency across the globe with the potential for substantial morbidity and mortality. So I mentioned that disruption of an atherosclerotic plaque is the most common cause of ACS. But what is atherosclerosis? Atherosclerosis is essentially lipid, fat, and inflammatory deposition within the arterial walls. And depending upon where these inflammatory cells and lipids accumulate, atherosclerosis can have various manifestations. When these plaques accumulate in your heart arteries, they can cause myocardial infarction. When they accumulate in your brain arteries, they can cause a stroke. When they accumulate in your leg arteries, they can cause peripheral arterial disease. And we all know what the risk factors are: obesity, poor diet, smoking, and the associated consequences of hypertension, diabetes, and dyslipidemia. So I want to start by talking about a tale of two cases that I think illustrate the concept about acute coronary syndromes and the different kinds of care delivery that we sometimes see. So I'll tell you about an 87-year-old woman with a history of hypertension and hyperlipidemia who presented with diaphoresis, nausea, and dyspnea. She presented to an outside hospital without percutaneous coronary intervention. And this is not uncommon where I trained and where I worked for some time in the northeast of the United States. Not every city has PCI-capable hospitals, and we frequently have to make decisions about what to do with patients when they show up to the emergency room when they can't get PCI. On arrival, she was found to have ST elevations at V2 through V4 with an elevated troponin, indicating this had been going on for some time on the basis of the other biomarkers. As often happens, acute coronary syndrome diagnoses are often delayed in these community hospitals, and the patient was initially treated with antibiotics. She was given aspirin and transferred to our hospital for a quote-unquote subacute Stemi, which unfortunately is not really a thing that exists. The symptom to transfer time was 14 hours. So we have an anterior Stemi in an 87-year-old woman, and essentially when she arrives at our hospital, she's visibly anxious, she's dyspneic, she denies any active pain. She's normotensive but tachycardic and slightly hypoxemic. Her physical exam and chest x-ray are consistent with heart failure. Her EKG shows actually near resolution of her ECG changes. However, she does have evolving Q waves. So the question is, what do you do now? She appears to have had an infarct. Did she complete the infarct? Should you just simply medically manage her heart failure, treat her with a statin, and maybe control her blood pressure and say follow up in clinic? Do you do a stat echo? Do you repeat the troponins? Do you give her thrombolytics? Do you give all of these drugs that are known to prevent consequences of acute coronary syndromes and maybe perform an angiogram? We'll circle back to this case later because I want to talk about the second case, which is a 56-year-old gentleman who with a smoking and hypertension history who also presented to an outside hospital. This gentleman actually had an episode of syncope while using a public telephone. Fortunately, bystanders performed CPR on this gentleman, called 911, and he was found to have ST elevations in the lateral leads. He was normotensive and is otherwise pretty stable. He did have intermittent chest comfort that preceded this syncopal episode and essentially had aborted sudden cardiac death. Unfortunately, he couldn't be transferred to our hospital. He was living on an island called Nantucket, which is off the coast of Boston. And in the winter, the northeast of the United States experiences these weather phenomenon called nor'easters, which are essentially cyclones of terrible ice and rain, and essentially prevented his helicopter transportation from Nantucket to Boston. And the anticipated weather delay was about 2 to 3 hours before he could get to our hospital. So the question is, what do we do now? Do we administer heparin, aspirin, statin, Plavix, and thrombolyse him? Do we do all of the above and transfer him for an angiogram? Do we repeat the troponins and maybe decide what to do later? There's a lot of decision making that goes into the management of these patients, particularly when they're not in an emergency department of a hospital that can perform a PCI. So just touching base on, again, what causes an acute coronary syndrome. I mentioned that disruption of an atherosclerotic plaque does this. And this is a cartoon description of what an artery looks like when the plaque ruptures. I'm not sure if you can see my arrow here, but this demonstrates accumulation of fat inflammatory cells within the arterial wall that results in a plaque. When this plaque destabilizes, it's almost like a pimple that ruptures inside the artery. And when the bloodstream sees this contents of the plaque, it forms a blood clot on top of the artery. And this causes occlusion of the artery that may cause an ST segment elevation myocardial infarction. When this clot is partially occlusive, it causes something called a non-ST elevation myocardial infarction. And that's essentially what distinguishes these two conditions, the two flavors of MI that I mentioned earlier. The reason this matters is because a STEMI requires emergent treatment, rapid reperfusion, whereas a non-STEMI can generally be treated safely within 24 to 48 hours. There are other causes of acute coronary syndromes that we're beginning to learn about, things called plaque erosion, which are a little bit distinct but essentially cause the same manifestations. And there are other causes unrelated to plaque, particularly in young women. They can get vasospasm, they can have microvascular dysfunction. We won't be talking about that today. Sorry, I'm going the wrong direction here. So what are the consequences of ACS? This is what an artery looks like from an autopsy of an individual who experienced a fatal acute coronary syndrome. They have a ruptured plaque that was filled with thrombus and occluded this individual's vessel. And this is what it looks like on an angiogram. As an interventional cardiologist, we see these patients in a different perspective. And this is actually iodinated contrast dye filling the left anterior descending of this individual's heart artery. And you can see here where it looks like there's a piece of the artery that's been bitten out of it. This is where the plaque ruptured and caused a filling defect, which is a thrombus, is a blood clot. This is a section of an individual's heart who died of an acute myocardial infarction. Healthy heart muscle looks like this, nice and red. In this patient, he has multiple areas of this white area. These are massive infarctions that this patient sustained that was ultimately the cause of this individual's death. And that's what can happen if you don't treat an ACS appropriately. You can die suddenly, you can develop cardiogenic shock, or you can ultimately develop heart failure and be plagued by this condition for the rest of your life. So we understand now a little bit about what ACS are, what causes them. Let's talk a little about how big of a problem it is. Every year, every couple of years, the Global Burden of Disease Investigators publishes estimates of the burden of various disease types. And I'll just give you a few highlights. The burden of cardiovascular disease across the world continues to increase. Cardiovascular disease attributable to modifiable risk factors like smoking, hypertension, diabetes continues to increase. And essentially the recommendation is that countries should invest in cost-effective public health measures to intervene to reduce these modifiable risk factors and reduce the disability and death related to cardiovascular disease. And that's fundamentally what this talk is about, which is about how to develop systems of care that can do that. Briefly, there's more work to be done in the context of CVD. As I mentioned, it continues to grow. Ischemic heart disease is the world's leading killer of all sources of cardiovascular disease. And when I say ischemic heart disease, I'm referring to coronary artery disease. But how does this happen? As I mentioned, acute coronary syndromes are the fundamental leading cause of death around the world. And this just shows, sorry, this isn't appearing correctly. But death is bad, but what about disability? Just to introduce a concept that I think is often thrown around and I want everybody to understand, it's something called a disability adjusted life year, or a DALY. What this attempts to do is capture both the mortality and morbidity. I like hearing myself talk, but not that much. So this is really it's an epidemiological measure, and what it attempts to say is, okay, well, what if you take a child who at age 3 develops malaria and their life expectancy is 86. So when that child gets malaria at age 3, they have 83 years of life to lose. Compare that to somebody who's 54 and they get TB, they may lose 3 years of life. And what about a woman who dies suddenly from postpartum hemorrhage at age 26 when her life expectancy is 86? Her expected loss of life is 60 years. So a DALY attempts to capture these changes that are related to how old is this person, what impact does this have on their quality of life, their duration of their life. And we know that disability adjusted life years due to ischemic heart disease in sub-Saharan African countries are actually comparable to high-income countries. So if you look at Central Sub-Sahara, Eastern, Western, and Southern, these are all comparable to many of the developed North American, high-income North American and Southern Latin American countries. So this isn't a problem only of developed countries. This is also something that's impacting low and middle-income countries significantly. And that's what this paper was about a few years ago, published by Gene Buckman's group. and looked at all the different risk factors that exist in sub-Saharan Africa. Essentially, folks smoke less, and there's less diabetes, but as you all know, there's a tremendous burden of hypertension in communities within sub-Saharan Africa. Apologies, not sure why this slide isn't displaying correctly. So the burden of CVD in low and middle income countries is significant. The WHO estimates that 80% of all cardiovascular deaths in the entire world occur in low and middle income countries. And the estimates of Stemi, or ST segment elevation myocardial infarction, are challenging to sort of estimate because there's not a lot of good data from these regions. But there could be upwards of 3 million cases per year. And Stemi tends to affect working age, younger people in low and middle income countries more than in high income countries, which, as we discussed, has tremendous direct and indirect economic consequences. And the cumulative economic loss from these events is estimated to be around almost $4 trillion. And so the implementation of evidence and guideline-based treatments has dramatically improved these outcomes, mostly in high-income countries. However, the outcomes remain suboptimal in low and middle-income countries, largely as a result of big implementation gaps, which is a very complex, multifactorial, and multifaceted issue. Before we touch on that, I'll touch on a recent guideline document, which I would all direct you to if you're interested in how the average clinician experiences a patient with chest pain. When somebody comes to the emergency room, the nurse, the doctor, when they first see them, what starts going through their head? What should they be thinking about? Well, number one, they should be thinking about taking a very careful history and understanding that sharp, fleeting, shifting type of chest pain isn't the same as central pressure squeezing type chest pain that's more consistent for a probability of ischemia. And understanding how these different historical features factor into the pre-test probability of whether or not the individual has ischemic heart disease or not matters. Similarly, an 80-year-old with crushing substernal chest pain is different than a 12-year-old with substernal chest pain. The likelihood a 12-year-old has ischemic heart disease, or even an 18-year-old, is very unlikely compared to a 60 or an 80-year-old who smokes or has diabetes. So context matters. And there are a lot of causes of chest pain, of course, and a careful history and an ECG are critical to the diagnosis of an acute coronary syndrome. In addition, troponins, as you all are probably aware, are a key tool. I'm not going to belabor you with these algorithms too much. As I said, I'd encourage you to review this paper. Regarding what we should do for patients who have non-ST segment elevation myocardial infarction, I mentioned earlier that a STEMI needs to go to the cath lab emergently. Patients with non-STEMIs, those who have a partially occluded artery, if they don't have hemodynamic instability, if they don't have severe heart failure, if they don't have severe angina, if they don't have a structural complication from their ischemia, you can probably wait a little while. 24 to 48 hours is probably a reasonable time to wait before you bring these patients to the cath lab. There are a variety of tools to understand whether a patient's high risk or not. One is called the TIMI risk score. And for all the residents and fellows out there, if you don't know how to calculate a TIMI risk score, I'm going to have Kuzema quiz you at the end of the day to make sure that you can. It's an important method for understanding whether or not a patient's at high risk for a complication from a non-STEMI or not. And there are a dozen different kind of stratification tools. I encourage you to look at one, use one, implement one in your practice. So regarding the acute management of STEMI, I just want to walk you through this algorithm because this is relevant to the two cases that we discussed and very relevant to the kinds of patients that you guys take care of every day. So if a patient comes to the emergency room who you think has a STEMI and your hospital can offer PCI, well, the decision's generally pretty easy unless they have a contraindication to STEMI. Closer. So that patient can be sent directly to the cath lab for primary PCI, assuming there isn't a contraindication. However, it gets more complicated when somebody shows up to a hospital where you can't do PCI, which is frankly the majority of hospitals throughout the world. So what do you do with those patients? Your options are to transfer them immediately, but what if you have a weather situation? What if you can't transfer them because the roads are bad? What are you going to do then? Well, your really only other option is to give fibrinolysis and hope you can get them to a PCI-capable facility at some time. But you need to be able to diagnose the condition. You need to know who can receive these treatments and at what times and when. So as I mentioned, urgent coronary perfusion STEMI is critical. Primary PCI is strongly preferred. And really need to try to coordinate with PCI-capable centers. So if you work in a clinic or a practice in any part of this country, reach out to Dr. Janabi and say, I want to find a way to get my STEMI patients to you, and he's going to help you make that happen. And that's critical. And Kuzaima takes call 24 hours, 7 days a week, so he's happy to show up to the cath lab anytime. So really getting these patients to the cath lab is key, and if you can't get them to the cath lab within 120 minutes, giving them fibrinolysis is really the next best option, and transferring them for PCI within 3 to 24 hours. There are also a variety of other medical therapies that we all have to be aware of, and I encourage you to review this. This isn't something I'm going to belabor you with. I do want to briefly touch on the background of coronary reperfusion. How did we get here? As an interventional cardiologist and somebody who enjoys history, I like sharing these stories because I think it's quite fascinating, the innovators who came up with these ideas. An individual who was an interventional radiologist named Charles Daughter developed the idea of transluminal angioplasty. He had an elderly woman who had severe peripheral artery disease, had a non-healing ulcer in her lower extremity, and he performed the first angioplasty to open up her superficial femoral artery and resulted in healing of her ulcer. This foundational innovation led to the ability to perform primary PCI today. Melvin Judkins developed the Judkin catheters that we use every day, that Dr. Kasenge so elegantly utilizes in the cath lab every day, the JR5, the JL4, these are all named after Melvin Judkins. The individual who brought coronary angioplasty to the forefront is a very dynamic, sort of James Bond-like character known as Andreas Grunzig, who was a German physician who performed the first balloon angioplasty in a femoral artery. And actually, when he presented the idea of doing this in the coronary arteries, everyone in all professional societies laughed him out of the conference hall. He presented this poster, you can see him with his head hanging at the American Heart Association, about his desire to design a coronary angioplasty catheter. And if you have a look at this prototype beast of a device compared to the balloons we use today, you can see why some people may have been skeptical. However, he did perform the first coronary angioplasty in a human. The first primary PCI was performed by a gentleman named Jeffrey Hartzler in 1980 in St. Luke's, Mid-America. He standardized protocols for primary PCI. He was an extremely innovative guy. He developed multiple complex PCI techniques, including 2 and 3 wires. For all the technical people out there, you know what I'm talking about. Legendary commitment to research and teaching. This individual was incredibly driven. He developed a prospective database to capture all the procedural details of every single patient he ever treated, and he documented every single outcome he ever had, good or bad. He hired an entire army of research assistants, and the database was eventually populated with patients that numbered in the tens of thousands, which was important for many of the seminal observations in interventional cardiology and underlie many of the guideline recommendations that I've already went through. So, jumping back to STEMI, why is reperfusion and STEMI important? Because time is muscle. The longer you wait to open up an infarct-related artery, the more likely you're going to get heart failure and a larger infarction. I'll just sort of skip through some of this. So we know this is actually an interesting meta-analysis that was done a few years ago that looked at how likely you were to be alive as a function of the various treatments you get for STEMI. So if you looked at whether somebody got revascularization, whether or not they got Plavix, whether or not they got statin, whether or not they got cardiac rehabilitation, whether or not they got an ACE inhibitor, a beta blocker, and you tried to understand what attributable fraction of these different interventions affected these people's outcomes. Not surprisingly, revascularization was responsible for 30% of the mortality benefit in patients treated with all of these therapies. And perhaps more interestingly, cardiac rehabilitation was a close number 3 to Plavix therapy. So I think this just underscores the critical importance of coronary reperfusion and the idea that if you don't treat these patients, they ultimately develop heart failure. And heart failure following STEMI is bad news. During a medium of follow-up, 50% of patients who develop post-MI heart failure were dead in this study. So heart failure following an MI is a significant cause of morbidity and mortality. We touched on this before, and it may happen in anywhere 15 to 35% of people. Prompt coronary perfusion, as I mentioned, to sort of repeat a point I want to emphasize over and over again, which is these folks need to get prompt coronary perfusion. And that window, that sweet spot where patients do stand to benefit is actually quite narrow. Even though the guidelines say 12 hours, we know from a variety of clinical observations that it's probably best within 6 hours. Once you get out to 12 hours, the likelihood that you still have viable muscle is quite low, unfortunately. And outside of 12 hours, you may simply be exposing a patient to harm by giving them a procedure, giving them anticoagulants, exposing them to an invasive procedure. So how do we do better? Well, as I mentioned, systems of care are critical to doing better for managing patients with acute coronary syndromes. And a few years ago, back in 2007, almost 20 years ago, the AHA convened a variety of cardiovascular professionals and said, well, how can we do this better? And what they wanted to do was redesign healthcare delivery to improve patient outcomes for STEMI care and utilize this process, structure, and outcome model which identifies the major domains of healthcare, and it defines the programmatic features needed to achieve success. This is one of those papers where I'd encourage you to read. I'm going to just briefly go through this. They proposed a variety of structural measures, not surprisingly starting with emergency medical personnel. The EMS who show up on the scene should be able to perform an ECG, communicate it by WhatsApp to a doctor, have an emergency department that has an ED rapid triage protocol for chest pain for STEMI, and of course having a 24-hour PCI capable hospital within transfer time. There are also a variety of proposed process measures. What happens when somebody picks up the phone and calls 911 or the equivalent emergency number? What is the time it takes to get an ECG when you show up to the emergency department and you say, I have chest pain? Did it take an hour for you to get an ECG? Did it take 5 minutes? Those are critical process measures that help inform how to improve the care of patients with STEMI. And some outcome measures, as you may imagine, how often are patients dying? How long does it take for them to get from various regional hospitals, and what happens to those who get transferred? So this comes back to this whole concept of time is muscle, and how can we coordinate all the various variables that go into getting a patient to this hospital as soon as possible when they have a STEMI. From the time they call 911, from the time an ambulance shows up, from the time they get in the emergency room to the time they get to the cath lab, how long does that take? How well is that being done? These are fundamental aspects to systems of care. And a recent paper published in Circulation attempted to follow up on this initial 2007 initiative. They said, okay, we've been talking about this for 20 years, since 2007. What kind of progress have we made? And what they found was that greater than 85% of the U.S. population is actually covered by this STEMI system of care that had been implemented, which is an incredible accomplishment. And more importantly than participation was improvement in outcomes. And over the duration of that years of participation, a metric known as a door-to-device time, which means how long does it take for a balloon to get inflated in your blocked heart artery from the time that you show up to the door. And that basically improved over the duration of this intervention, indicating how effective this system of care implementation has been. And that extends all the way to 2019. So they identified a variety of barriers to progress in terms of implementing a system of care. And so, interestingly, some of these are non-modifiable, right? If you live in the mountains and you're surrounded by forest and you don't have roads to your house, you can't make it to the hospital. We can't change that. But what we can change is when you do show up to the hospital, can your doctor reach the doctor who has a primary PCI capability? Does that doctor know how to do an ECG? Has that doctor the ability to perform a troponin, for example? So I'm gonna skip through this because we're running a little short on time, but there are a variety of unique challenges that are faced by individuals within sub-Saharan Africa regarding acute coronary syndromes. And I think one of the most important ones is that the time that a person comes to the hospital is significantly delayed from the time they experience chest pain or shortness of breath to the time they show up, and you guys know this better than I do. It's significantly prolonged. And that's one area where public outreach campaigns and improved communication between community facilities, interventional facilities could be improved upon. So patients need to understand what symptoms they should be worried about. Doctors need to know which patients need to be transferred urgently. And as I mentioned, pre-hospital delay remains an important contributor to poor clinical outcomes and higher mortality in low and middle income countries. And again, most patients don't seek treatment early because they're not simply aware of the signs or symptoms of acute coronary syndromes. Here's another paper that I put on your radar screen, published about 2 years ago. And this paper was essentially similar to that paper in 2007. It said, how do we improve systems of care, not in high-income countries, but in low and middle-income countries? What is unique about low and middle-income countries that we need to develop specific interventions that address the challenges to some of the issues that are faced by providers within low and middle-income countries? And what they observed was that no focused recommendations exist for these regions. We have focused guidelines for the United States, for Europe, where all these guidelines were developed and implemented. But we don't have ones unique for Tanzania, for Pakistan, for Iraq. All of these countries are different. They're different culturally. They're different socioeconomically. So are these guidelines applicable? We don't know. And so the challenge is to you as a community to develop your guidelines, to develop the data that informs these guidelines so that you can improve the outcome in management of your patients with acute coronary syndromes. I'll breeze through this. This is a pretty quick, it's a pretty complex algorithm, but essentially the thrust of this algorithm is the best strategy in places where you cannot administer primary PCI is to give thrombolysis and send them to a facility that can do PCI. We do that in the United States every day. Dr. Akhtar works in Tennessee, and I'm sure he receives a lot of patients who have received thrombolysis from remote parts of Appalachia. So, you know, as I mentioned, I think pharmacoinvasive PCI is an important intervention, and we can talk about that. One thing I want to briefly touch on are what are some of the unique solutions that individuals have come up with over the course of the last 10 years. So an organization called the Latin America Telemedicine Network said, look, we have our own challenges. We are not North America. We are not Europe. We need to figure out how to improve STEMI care in our population. They said, we're going to use telemedicine. And this is another paper I'm happy to share with you. Essentially what they found was that utilizing a telemedicine strategy, they reduced the time from first medical contact by 40 minutes. More importantly, they reduced mortality by almost 50% in these patients who were being treated with this telemedicine program. It's an incredible reduction as a result of this. Another option is to use WhatsApp. We alluded to this earlier. Can an emergency medicine doctor pick up his phone, take a picture of the ECG, send it to Dr. Kasenge and say, what do you think? Do I need to send this patient? Should I give thrombolysis? Simply the use of WhatsApp could really impact the way patients are treated with STEMI. This is a paper about patient education. We mentioned that patients don't know what symptoms are concerning for STEMI. So how do we go out into the community and begin to educate patients? Go on TV, give interviews, visit schools, visit colleges, visit workplaces, tell people about the symptoms they should be concerned about and how to live healthily, more healthy. So going back to the patients that we mentioned, what do we do with this elderly woman who essentially was in heart failure after experiencing delayed presentation from a myocardial infarction? Well, we gave her all those medications and we decided to perform an angiogram, and we thought we'd try to do PCI if we could. And this was consistent with the guidelines. Even though she didn't have persistent ST elevations and didn't have angina, she was in essentially cardiogenic shock. And so we took her to the cath lab. This is just a few still images. This is the pre-PCI angiogram showing a mid-vessel occlusion of the left anterior descending. This lady was incredibly sick, and this is the defibrillator pad on her, so I'm sorry it's not a great picture. This is the post-PCI result, really diffusely diseased, sick artery in a patient who had sustained a massive infarction, and unfortunately, because of her delayed presentation, after 5 to 7 days in the hospital, died of progressive shock. On the other hand, the individual who received prompt thrombolytic therapy did quite well. He received thrombolysis in Nantucket. In about 8 hours, the weather cleared. He was put in a helicopter. He got to our cath lab. We did PCI on a large diagonal branch, and he walked out of the hospital 2 days later. So in conclusion, the prevalence of acute coronary syndromes, in particular STEMI, appears to be rising at an alarming pace in low and middle income countries. However, the data remains sparse. Prompt coronary reperfusion in STEMI is critical to reduce infarct size and heart failure. More data on the incidence and optimal management of ACS is needed in sub-Saharan African countries. Systems of care designed to optimize implementation of these guidelines for the diagnosis and management of STEMI are critical, and additional investigations are needed in the region to evaluate interventions that address the unique challenges and culture of the region to reduce the burden of acute coronary syndrome. Thank you very much.
Thank you very much, Dr. Mazen, for the elaboration. Thank you very much for that presentation, and hopefully now we'll get more STEMI referred to JKCI, and we always welcome this WhatsApp conversation. I think we have a STEMI group of WhatsApp as well, so doctors do send ECGs to us, and hopefully we'll improve, and we'll have a protocol as well in next 1 or 2 years. Mazen, you can have a seat, and I'll introduce our next speaker, and then we'll have a 5 minutes question quiz after the presentation. So Dr. Yasir Akhtar, his first time here in Tanzania, I guess. Oh, you have been in Tanzania before? First time in Africa, but he's been in Pakistan, so it's like Africa as well. Yes. So he's an interventional cardiologist and a cardiac cath lab director at Tenowa Health in Knoxville, Tennessee, and he completed residency in Indiana University, where he was associate professor, and he's been practicing for last 8 years for specialized in complex coronary interventions, structural heart intervention, and peripheral interventions. So today he will give us talk about peripheral artery disease and interventions in peripheral artery disease. And I think he'll touch also on endocarditis as well, and the new role of intervention in endocarditis. So Dr. Yasser, you are most welcome. I'll just load your presentation. Amani.
Thank you, Dr. Kuzema, for the kind introduction, and thank you, Dr. Janabi, for the wonderful hospitality and for the opportunity to be here. Everyone's been wonderful. We've had a wonderful time with all the faculty, staff, nurses, everybody in the lab, the interns and the fellows. So thank you for this wonderful opportunity. This has been fantastic. The hospitality here and the eagerness to learn, and we've learned as well. There are new techniques that we've learned on how to bend wires and whatnot. So it's been a great mutual exchange of skill. I think we can do the endocarditis one first, for the peripheral artery disease. There should be 2 presentations. And we can do this one. Okay. Okay. All right. So this is I have no relevant disclosures. I was going to talk about the percutaneous management of infectious endocarditis. This is just an entity just fell in my lap. This is not something I specialized in, but I just wanted to share this experience as we sometimes think of the West as a resource-rich area, but there are areas which are resource-limited, like our area from Tennessee. I don't have any financial disclosures. So we're in the south to middle of the country. We're considered the South. The South is very different from the East Coast, from the West Coast, which is the traditional stuff you see on Hollywood. But we're a very different country compared to the rest. And if you've read about the Civil War, we were on the losing side of the Civil War. So we are currently experiencing a huge drug problem, a drug epidemic. In the last year, there were 700 deaths from drug overdose. There were 7,000 overdoses total in 2019 from drug use. So relative to the population of our area, which is around just 1 million, this is a huge number. So this is a huge, huge problem. When Obama was president, he declared a state of emergency because of this drug problem. So this is a problem we've essentially, in essence, created ourselves. So I'll present a case history. A 30-year-old female, unresponsive, presents with hypotension, shock, had to be intubated, has a history of drug abuse with cocaine. High white count, she's growing methicillin susceptible staph aureus in her blood, platelets of less than 10,000, low haptoglobin, high procalcitonin, suggestive that she is in septic shock. Her creatinine is this is twice as high. I get confused with looking at the creatinines here. Someone told me that creatinine's 100. I thought, how's this patient alive? And I was like, this is a different scale. So creatinine 2.5 is still bad. The blood cultures, like positive. The transthoracic echo, I'll show pictures of the ICE imaging later. Severe tricuspid regurgitation, her valve was destroyed, and a very large vegetation. Continued antibiotics. The surgeon says she's too high risk. Her platelets are less than 10,000. She'll bleed to death. We're not going to operate on her. Poor respiratory status. She had left pneumothorax, septic pulmonary emboli, eventually had a tracheostomy, a PEG tube placement, a G tube for feeding. So she was in poor condition. And this is after 15 days of care. So we repeated a transesophageal echo because she wasn't getting better. Still having fevers, her cultures were still positive, and she still had a large in fact it grew in size. She had a large 3 by 3 centimeter and a 3 by 0.7 centimeter vegetation. Persistent bacteremia, fevers, respiratory failure. One option was, do we consider hospice on this patient? We have nothing else to offer. We've given her antibiotics, this duration. We discussed percutaneous intervention. How can we take out this? The source of the infection has to leave the body. Otherwise, she's not going to get better. So the indications of valve debridement or removal for valve for surgery is if there's severe heart failure, valve dysfunction, if it's a prosthetic valve, if there's an abscess, recurrent embolization, which she had in her case, or if the vegetation is very large on the tricuspid valve. So one percutaneous option that has gained some traction in the United States, there were a few cases reported here and there, is the Angiovac device. This is a large tube, 22 French, the size of my thumb, which is inserted in the neck or in the groin. It sucks blood out, a lot of blood out. It filters it through extra membranous oxygenation and you send it back to the blood. But it's $25,000. And the ECMO circuit is $20,000. So our hospital really can't afford $50,000 of care for one endocarditis patient who is usually not insured. So one of our hospitals actually went out of business and bankrupt because of this problem in the inner city of Knoxville. It requires anesthesia, risk of RV perforation, there's poor clinical success. So what we decided to do, there's another catheter that's meant for PAD intervention. This is probably how I got stuck in this field, is that I do PAD intervention for cold legs. So we thought, how about we try this catheter? It's still within FDA guidelines. We're putting a catheter in a blood vessel. And people use it for pulmonary embolus, so we're just going to take a different turn and go into the right atrium instead. So we used a steerable sheath. We used intracardiac echo. This is FDA approved for clot aspiration. This is a glorified vacuum cleaner. It's a big straw with a vacuum attached to it. There's nothing more. This is a picture on intracardiac echo of the vegetation. So you can see right in the center here that this is all infectious endocarditis. And then we performed aspiration. We turned the vacuum cleaner on, and hopefully you can see it, and we started aspirating the vegetation, taking the infection off. And you can see pieces and bits and pieces of being pulled away. This is our catheter here. You can see the right atrium is the top chamber, the lower chamber is the right ventricle. So we had about, I think, maybe a half a liter of blood loss. There was a little piece that wasn't coming off, and I think this was just a piece of a torn tricuspid valve. But otherwise, we had large chunks of pieces come out, and we sent it to pathology, and my first reaction was, that's probably myocardium and heart valve. But fortunately it wasn't. It was all infection. There was no heart valve tissue. There was no myocardium in the biopsy result. Fevers resolved. Leukocytosis resolved. Hemoglobin went down to 6.5, which is low, so we transfused her 2 units. She was weaned off the vent and discharged after a total stay of 45 days. So we decided to do a case series. We became notorious, I shouldn't say famous, because the hospital didn't like that we were getting referrals from the university for endocarditis aspiration because it doesn't make money. But we became notorious for this, and we did a case series because we had many cases. I'll just quickly go through this. A lot of patients were in septic shock, almost 1/4 of the patients. This is a series of, I think we did 20 or 30 patients or so. Large vegetation, everyone had respiratory failure, septic pulmonary emboli, bacteremia. Most cases were Staph aureus. This is a notorious bug that doesn't get out of the system until you get rid of its mothership or wherever it's harboring a home. Almost half of the Staph aureus were methicillin resistant, half were sensitive, but despite that, we're not clearing with antibiotics. There are other pathogens, Candida, Pseudomonas in some rare cases. We had no intraprocedural death, no vascular complication, some blood loss, 1/4 needed transfusions, and there was a good reduction in almost all cases. The only patients to have died in the index hospitalization were the ones who were 3 out of 5 who were in cardiogenic shock. Those who were not in shock yet all survived. And those who had repeat negative cultures also all survived. There were some that still had positive cultures. These were patients who were in septic shock. Once shock hits, and it's similar to cardiogenic shock. Shock is a different animal. Once you've hit shock, you have cytokine release. It's a whirlpool or a whirlwind of death. You've initiated the death cascade, and it's very hard to reverse. So our hospital mortality was only 3. In the first 10 cases, we had large amounts of blood loss, but the next 20 cases after that, our blood loss was majority less than 500. So in conclusion, using an 8 French system, which is almost the size of doing a heart cath, feasible, safe, effective, and it's pretty effective for high-risk surgical in patients who are high risk for surgical debridement. And surprisingly, we were thinking that maybe the surgeons would be mad at us that we're taking business from them, but they were actually happy. Like, we don't want to deal with these patients. You can have them all. So when our surgeons get called for infectious endocarditis, they call us. They're like, no, have them deal with this. We don't want to deal with these patients. So we've published these 2 studies on our clinical outcomes. So I can give you copies of this later if you need it. We compared our outcomes to surgical resection, and the mortality is the same in patient cohorts. This was in conjunction with the University of Tennessee. So in future directions, we've actually have a larger catheter, and we have done 70 of these cases now, and now we're doing majority with a larger device. We're starting to treat mitral endocarditis as well. The people who had the Angiovac were mad that we're using this newer device, so they came out with a cheaper device. They said, how about you use our cheaper device? We made one just for you because you won't use our expensive stuff. We're going to compare outcomes to surgery, and in collaboration with Mayo Clinic and Columbia, we're starting a registry along with them. So good things ahead. Thank you very much. I can answer questions until we can upload the PAD presentation if we want to do that quickly.
Yes, sir. Did you use like aspiration catheter you were using in the suction of thrombi? The same like aspiration catheter?
The aspiration catheter is specially designed. It's try different things. Yeah.
But I think we'll discuss before you leave. We see a lot of endocarditis here, and they all end up to the surgeon. So it will be lovely to consider a possibility of doing the procedures here.
Right. Yeah, and that's it. They're simple procedures. They usually take 20 to 30 minutes to do. You don't need general anesthesia. They're pretty quick, and you don't need a lot of equipment. Just this penumbra canister is very easy to retrieve and easy to get. It's about this size. It's really small.
I think you'll connect us with the suppliers, the vendors, and then we can see. So we'll have a discussion before you leave. Yeah, but we have now 363 doctors around Tanzania. The number is updating there, following. So I think it's come up to be educative. Kusema bado sana, tuchukue maswali. Oh, it's here. Okay. Is that your small hospital?
Yeah, this was the large one that got shut down. It was a 100-bed hospital. And we were unfortunately close to the homeless shelter, so anyone who was indigent had to come to our hospital. There was a point where out of the 200 active beds, 15 or 20 were endocarditis patients. So at that time we were doing surgery. When you do surgery on these patients, they take up OR space, surgical resources, and there's no net benefit. Where we were run by a for-profit hospital, so they said, well, this hospital is losing money. I think we were losing $1 million every month almost. So the people who owned us shut us down. So we had to move to the other hospital. So I'll quickly, hope it was in the interest of time, go through a more bread and butter topic, but an important topic, peripheral artery disease, current challenges and some future prospects. I'll try to go quickly so we can touch base on the cases that we have at the end. Peripheral artery disease is very common. 200 million Americans suffer from it. That's almost 10% of the population over the age of 40, and occurs very prominently in diabetics. Almost 33% of all diabetics. The prevalence is a little bit higher than coronary artery disease. So it's technically you don't die of PAD. That's why you don't hear about it, but you lose limbs. So it may not cause mortality, but causes a lot of morbidity. Each year there are 160,000 amputations performed in the U.S. and one of the downfalls of our healthcare system is that surgeons get paid a lot of money to perform amputations. So there is not a lot of interest to prevent it, because why would you do something that makes less money? So unfortunately that's the system we're in. But fortunately they have interventional cardiologists who have nothing better to do than to fix legs. So that you know, when heart disease gets better, we have to look for other things to open. So now we're starting to open legs. So PAD can be diverse. Half of the patients can be asymptomatic and still have leg disease. About 10 to 30% can have claudication. Claudication is when you walk a certain distance, you start having cramps or pain in your legs. 1 to 2% can have an entity called critical limb ischemia. That is when you are having pain at rest, or you have ulcers in your legs that are arterial, or you start getting skin change. This is almost like acute coronary syndrome, as Dr. Mazen mentioned, of the legs, meaning something has to be done quickly, otherwise you're going to lose your leg. But again, remember, it's only 1 to 2%. This is not every patient with a 80% SFA is going to have critical limb. We had a patient today who had some posterior tibial, his posterior tibial was occluded in his leg. Was not really having symptoms. So we're like, okay, you have PAD, but you'll be fine. You're not having any symptoms, you're asymptomatic, you'll probably need to exercise, statin and all that, and we'll go over that. So I think we mostly went through this. I'll quickly go through this. So the 10-year survival rates for PAD are pretty abysmal, meaning if you have severe symptomatic PAD, there's a 50% chance that you'll be alive in 5 years. Those are horrible numbers, and it has to do with if these people develop anything. Ulcers, infections, heart disease. A lot of the operators have done heart caths on people with peripheral disease. It's a nightmare to have to go through all that plaque and the tortuosity and the embolization that occurs. So most of these resources can be found. I'll quickly go through this. So one thing in the PAD world you'll hear is the Rutherford category. These are categories from 0 to 6. 0 is asymptomatic, 1 to 3 is claudication, 4, 5, 6 is essentially critical limb. And I mentioned this because traditionally, for Rutherford 6, we used to say, you have a gangrene, we'll have to chop your leg off, there's no other solution. But data is coming out, if you intervene in these patients, you can save their limbs. You may not save everything, you may get away with just amputating the toe or a few, or just the entire metatarsal, but not the entire leg. So and sometimes we may think that, well, he needs an amputation, might as well amputate everything. In a patient who has just a metatarsal amputation compared to an entire leg amputation, for him it's a big difference of balance and ability to walk and prosthesis. This has almost created a new specialty in the US, and I don't know if they exist here, but podiatrists are foot doctors. They specialize in the foot. They'll actually do amputations. There's a little friction between them and the orthopedic surgeons and who gets to amputate. But because of that specialty, we're making progress, because what we tell the podiatrist, look, if you lose the foot, you have no job. You can't work on anything else. So it's in your best interest for the patient to have a foot. Otherwise, you just lost a patient. So these are some risk factors, diabetes, just the usual things that also cause coronary disease, but smoking is a big contribution of PAD. I tell PAD patients, if you are going to smoke, there's no point in us intervening, because you will come back. Your stent will close down, you'll keep progressing. So work on smoking cessation first, and then we'll work on trying to get your legs open. But this smoking is adding fuel to the fire. So there are ways to diagnose it. Ankle brachial index is one way. This is roughly, and you can look this up later, but this is essentially you're looking at the blood pressure between the arms and the legs. If the legs have lower blood pressure, that means there's a blockage going on somewhere. Other ways to diagnose this are arterial duplex, looking at the actual flow with ultrasound. The downside is you need a technical person, an ultrasound expert to do this. It's time consuming, but it's accurate. But the other downside is it doesn't look at the iliac arteries because you can't really ultrasound them. That's where CT angiography comes in, which may be one of the best modalities. You can actually see the entire tree of the legs. This may not look at the arteries below the knee very well. Sometimes the dye doesn't reach there. But that's where you have to consider coronary or essentially peripheral angiography. Just like you do a heart cath, sometimes you have to do a diagnostic leg angiogram. You go in, you shoot dye, and you look at the arteries. And this allows also for immediate intervention. So there are complex algorithms that the American Heart Association have come out with trying to diagnose critical limb ischemia. There are multiple differentials of leg disease. Venous disease can occur when you have obesity, hypoventilation syndrome, or if you have elephantiasis, which may exist in this part of the world where your venous system's clogged and you develop venous ulcers. And I think I have pictures of venous versus arterial ulcers. Yeah, here they are. So an arterial ulcer is generally painful. It's distal. It's at the tip of the toes or on the lateral malleolus or medial malleolus. There is usually little bleeding because there's no blood flow. And there may be areas of accompanied gangrene, and when you do an exam, you'll have reduced pulses. Venous ulcers are often, the legs are big, they have varicose veins, they're usually not painful, they're painless, and they're recurrent and they're very large. They're usually on the shin and upper surface. They're usually on the shin or they're on the upper surface, and they're exudative. So one concept to understand when dealing with peripheral artery disease is the angiosome concept. Knowing that there are three major blood suppliers of the lower extremity: the anterior tibial artery, the perineal artery, and the posterior tibial artery that provides blood to the plantar aspect of the foot. So depending on where the ulcer is, you have to focus on opening that particular artery. So if a lesion is on the perineal side and the blockage is on the anterior tibial, there's no point in opening the anterior tibial because the perineal is the artery that needs to be opened for critical limb. So knowing where the ulcer is in accordance to the artery is very important. So what do we do for a treatment plan? It's similar to cardiac care. Foot care, risk factor modification, control your diabetes, avoid smoking. exercise. Exercise is extremely beneficial, as Dr. Mazen mentioned about rehabilitation and how effective that is. Guideline-directed medical therapy and exercise is extremely effective. And studies have shown that they are less likely to receive guideline-directed medical therapy compared to cardiovascular disease. So aspirin or Plavix is recommended. Both are not recommended. There's not a lot of data out there to use both. Regarding anticoagulation use, such as warfarin or rivaroxaban, there is a study out called COMPASS that shows that these patients have less strokes when you put them on anticoagulation. So it doesn't help the PAD. So some physicians use it, some don't. It hasn't become a class 1 indication yet, but the field may be going there, where instead of using an antiplatelet, use an anticoagulant. Cilostazol, maybe 10 years, 20 years ago, was popular. The thought is it makes the red cell flexible and can get down the stenosis and actually perfuse, but it should be avoided with heart failure. I've seen more complications with cilostazol than any benefit. And the data shows, if you read the trials, they'll show, well, instead of 5 feet, our patient can walk 6 feet with cilostazol. Is it worth putting them on a medication? Not really. So statins are probably, after aspirin, the most important drug because they can actually modify plaque. And this is a class 1 recommendation. Exercise, like we mentioned, foot and wound care are extremely important. So wound care is a separate specialty where they will, nurses will check on the wounds. They'll even provide hyperbaric oxygen to the wounds to help them heal. These are just current guideline associations that recommend endovascular revascularization first. So unlike heart disease recommendations where you can consider CABG or bypass first sometimes if there's multivessel disease, for peripheral vascular disease, if endovascular approaches are an option, that's actually considered first. There's a reason where vascular surgeons in the United States are all learning how to do this because they know this is better, but they're unfortunately not very good at it. So there are 3 aspects to peripheral intervention. Atherectomy, where you remove the plaque or disrupt it, balloon angioplasty, and stenting. And we're still learning a lot about this field. The legs are not the same as coronary. In coronary, we balloon, we stent, sometimes atherectomize and done. But we're noticing that we need to avoid putting metal in the legs because that actually has sometimes the opposite effect. You can have a chronic total occlusion, soft plaque. You need to understand how long the lesion is. The patency rates are very poor in the leg with balloon angioplasty, even stenting, especially when there's calcium. So calcium has been a major issue treating PAD. There are different devices out there. There are drills. These drills are all some form of metal with diamond dust on it that burrs through and drills through the artery, and it pulverizes the calcium to the size of much smaller than that of a red blood cell. So it eventually gets, you either urinate it out or it gets destroyed by the spleen. Laser is an option as well. These are different atherectomy devices. They use the concept of differential cutting. It's almost like shaving, where when you shave, you don't cut your skin, but it'll cut the hair. Similarly, these atherectomy devices, they will destroy the hard plaque, but they will not touch the vessel, in theory. I was demonstrating a Turbo Hawk once, and I thought it was the same device. Oh, is this the one that doesn't hurt your finger? And I sliced my finger off, and like, okay, I'm not using this again. So these are just different devices, atherectomy devices. There are different forms of drug-coated balloons. So drug-coated balloons are a new concept in the legs, and they're eventually going to make it to the coronaries as well, where you deliver almost an anti-cancer agent into the vessel to prevent the plaque from coming back. So there's still a lot of studies done on the efficacy of different forms of balloons. Some may be better than the other. Every company has a different balloon, but this is now the treatment of choice as opposed to putting a stent in. Stenting is the last resort option in a leg. How are we doing that? Okay, we have 15 minutes left. So some drug-eluting systems or stents might be better than the others, but again, the patency rate is 70 to 80% in 2 years. For us in the medical field, we don't like that. We don't like patients coming back again and again, even if it's maybe 10 to 20% of your patients coming back. So this is stenting is not the ultimate solution. We'll just focus a little on critical limb. This is just a picture of a popliteal, the before and after picture, where it was completely occluded at the popliteal, and after atherectomy and balloon angioplasty only, it looks much better. One difference we have in the peripheral world compared to the coronary, we're not aiming for a pretty picture. We just want to reestablish flow. So if there's residual 50, 60% stenosis, you leave it. You balloon it, you might balloon it from a 99% stenosis to a 50, 60%, that's enough. Usually with the coronaries, you're trying to make a beautiful picture. It's very different in the periphery. So with peripheral intervention, even in Rutherford 6, which was traditionally all amputation, it improves wound healing. There have been updates by the American Heart Association guidelines about revascularization, and major amputations have gone down over the years with increasing number of angiograms and vascular encounters. And so this has overall improved PAD care with reduction in amputations as you improve things. So this is just another case. Patient is 6 weeks knee replacement. I'll just show the angiogram, and after the unfortunately, I think this will play. Essentially, they had a lesion right behind the popliteal. This was open with a retrograde approach, so you access the anterior tibial and go up, and then perform atherectomy with a device, perform balloon angioplasty. And I'm sorry, but this is the after shot, where you can see there's much better blood flow. You can see restoration of flow. The before shot essentially had no blood vessels. You couldn't see anything. This is another case. You can see the discoloration of the toe. This is a dragonfly tattoo. This is the, you can see a little artery here. This is the ostium of the superficial femoral artery. So the superficial femoral artery is completely occluded. And you can see essentially no vessels here, and barely trickles of blood flow. So this is after stenting, and stenting, balloon angioplasty, atherectomy. You can see the restoration of flow, even to the lower limb. And you can see how the foot is now nicely colored, and an otherwise foot that would have likely been chopped off. This is before dinner. You can, enjoy these pictures. Otherwise, these are hard to look at. Another case where I think this patient had a bunion removed. Their SFA was found to be when their wound wasn't healing. They later realized that they have peripheral artery disease. Their SFA, their right thigh artery, was completely occluded, 100%. So with a retrograde approach, balloon angioplasty was performed, and there was restoration of flow. So you can see there's still little blockages here and there. We don't aim to open up everything. Just get enough flow for the leg to get perfused and for the wound to ultimately heal. So on the right panel, you can see this wound is now completely healed, and you've avoided another amputation. A few more cases where on the left you can see a before where there's no anterior tibial, and an after where there's essentially restoration of flow. So just challenges building a program. This has to be multidisciplinary. We sometimes joke around about the interventional radiologists want to do this, and the cardiologists want to do this, and the vascular surgeons want to do this. In essence, everyone has to work together to achieve a good result. You still need vascular surgeons to sometimes do bypass, amputations. You need your podiatry colleagues. You need wound care. You need infectious disease. You need a whole team-based approach to deal with these complicated patients. This is not a single man sport or a single woman sport. Everyone has to play together and create algorithms and use teamwork to help these patients out. So a CLI team, essentially, it may consist of a revascularization specialist, but that's a small piece. Us as interventionists are a very small piece of the puzzle. You have your non-invasive specialists who are reading the ultrasounds, referring the patients, seeing the patients in clinic, nurses, nurse assistants, the podiatrists, the kidney doctors, infectious disease, wound care, even the triage and the phone triage and the schedulers play a very important role in managing these patients, because you need to understand how quickly does this patient need to get their intervention, and am I going to miss the window. So in conclusion, there's high freedom for major amputation in the recent Liberty study, significant improvement in all Rutherford classes, and even primary amputation may not be necessary in the severest form of PAD. I think that is it. Thank you very much.
Thank you very much, Dr. Yasser, for enlightening us with these presentations. I would request Dr. Mazen and Dr. Yasser to have a seat here for questions on the podium, please. Dr. Mazen? So I think we'll have 2 questions for each from the audience. Yes, for the time. So I think Dr. Nyagasa, yes, he is a vascular surgeon and a cardiothoracic surgeon at JKCI. So,
thank you very much for the yummy presentation from Mazen and Yasser. But I have several questions to Yasser. My center of question is during suction to a patient who have endocarditis, how seldom did you meet with like seepage of the debris or during suction of the clots? Because when there is endocarditis, also sometimes you might meet with an abscess in situ. So how do you go through this, and how frequent did you meet with like conversion from aspiration to opening of the chest and doing other stuff? Yeah, that's question number 1, if you won't mind. The other thing, how do you know that you didn't, during suction, how are you sure that you won't cause like pulmonary embolisms because of the seepage of the debris?
Is this on? Yes. Great questions. Absolutely. So regarding embolizations, these patients have already embolized. If you look at their X-rays are full of embolic debris. Probably during sectioning, we probably do cause more debris. We have thought about putting filters in the pulmonary artery, but in general, the suction is strong enough that with the newer device, the bigger devices that you use, it usually pulls the whole thing off in one piece. When we were using the smaller device, the 8 French, we sometimes saw that when we pulled it off, a few pieces went down the pulmonary tree. I think out of the 80 patients we have done so far, maybe about 75, we've had one patient who became hypoxic and had to be intubated for a few days and then got extubated. Some of these patients develop chills and rigors while they're on the table. Most of these patients can tolerate septic emboli to the lung, because you have vascular circulation in the lung, and with the antibiotics, it'll treat the pneumonia. When the infection is living on the valve, it's persistently causing emboli, and it's not getting treated with antibiotics. So you can treat the pneumonia much easier, better than treating the valve infection. So that's one of the principles we use, that we need to get rid of the valve infection where it's all coming from, and they'll tolerate it. With the newer device, the CAT-12, which is a much larger bore system, as long as the vegetation size, with the algorithm we formed is if it's less than 3 centimeters, we'll use the CAT-12. If it's larger than 3 centimeters, we'll use the AlphaVac, which is 22 French. If there's an abscess and they need extensive cardiac debridement, then we tell the surgeon, look, this is not going to work, because you actually have to debride the valve. So we've noticed that in patients who have had recurrent endocarditis and no one will treat them, and they come as a transfer, they've had endocarditis 5 times in the last year, they have an abscess by now. They have to be surgically treated. So we will try to push the surgeons to do something, because our surgeons don't operate anymore. They want this as primary approach, and only if this fails, then they'll surgically do something. Also, this is a test for the patients, because they tell the patient, we'll suction out your vegetation if you become clean of IV drug use and stop using drugs for 3 months. We will bring you back to get a new valve. So this therapy isn't meant to replace surgery, but to delay surgery. Because if you replace, what was happening in the US is once you replaced the valve acutely, they would still keep using, and 2 months later, they would come back with their infected valve. And then they would get surgery again. Then 2 months later, another surgery. So the US surgeons have decided that drug abuse patients get one valve. You can choose wisely when to get it, but you will get one valve in your valve. So,
Maybe my last question would be on the PADs. If I get you that you are like discouraging stenting, but like the patient you are meeting in the PADs, they got like segmental CTOs, severe occlusions. So if you do balloon in like in the proximal, still in the downstream, maybe you have a 4-5. This, it won't work in our place. So what do you advise to Professor Janabi? Are we going to base on balloon or stent?
yeah, I think for certain disease, for maybe aortic disease, if your distal aorta is occluded and you have multi-level disease, surgery still has a role. Fem-fem bypass, aorto-fem, aortal axillary bypass, those still have a role. But every vascular surgeon in the US is doing endovascular intervention. So I would suggest that he buys you your own lab, has your own endovascular suite. So it, so in fact, vascular surgeons have, because they're very powerful in the US, they can actually perform they have surgical centers. They have their own vascular labs. They're not affiliated with the hospital. So you can make your own shop and have your own cath lab. But every vascular surgeon in the US does endovascular first. In fact, they sometimes say that's better because they say, on the table, I'm going to try to open this SFA. If I don't open it, I'll convert it to surgery. They have hybrid suites where it's a cath lab plus OR combined. And if you can't open it, then you just convert to surgery, and that way they have single treatment.
Thank you, Yasser, for elaborating on this. Thank you, Nagasa, for your great question. So the next question is for Dr. Mazen. Dr. Mazen, this question is from online. What are the prevalence of left ventricular aneurysm in patients with Stemi? And how does it affect the management of this patient when they come with Stemi?
That's a great question. It's one of the reasons that we need to promptly reperfuse patients, is to reduce the incidence of those complications. I couldn't comment on the contemporary incidence of LV aneurysm or LV rupture. Before thrombolysis, before PCI, that's how patients used to die. Their LV would rupture. That's less common, thankfully, significantly less common. When you do see a patient with an LV aneurysm today, you generally want to think about whether or not they have an LV thrombus and whether or not they need to be anticoagulated. And an echo with contrast can help that. But as far as how it influences your decision-making regarding reperfusion, if they have an aneurysm, unfortunately the damage has already been done. And reperfusion generally doesn't have a good role for those patients who have experienced that kind of mechanical complication. And the same is true for a ventricular septal defect, which is another complication of an untreated MI. Ischemic mitral regurgitation is a little bit of a different story. There may be a benefit to reperfusing in those patients, but those are the three principal mechanical complications that you see from an untreated MI, which is a septal rupture, septal defect, free wall rupture, aneurysm, or ischemic MR, and those are very challenging to deal with, but fortunately much less common today.
So if I got you correct, every patient who comes with STEMI should have an imaging first before going to cath lab?
By imaging, you mean an echocardiogram?
Echocardiogram.
I wouldn't say that. I think it's one of those things that who has a STEMI, an echo could delay. And actually, one of the things our emergency departments tend to do, generally unnecessarily, is get a chest x-ray. Somebody says chest and pain in the same sentence, they think they need to get a chest x-ray. And if the EKG shows ST elevations and everything else screams ST elevation, then you should just proceed with taking them to the cath lab. Don't delay getting a chest x-ray. If you have concern for an aortic dissection, an echo is a great tool. Chest x-ray can be helpful. But when everything's consistent with that diagnosis, don't delay getting the patient to the lab.
Thank you very much. So with limited time, Dr. Mazen, Dr. Yasser, any last comments to us and before we proceed?
Just thank everybody again. Thanks, Dr. Janabi, for putting this together. Thank you for everybody's hospitality. We're so happy to be back. It's been a pleasure seeing you guys again, first time in 2 years. I hope this to be the first of many visits with Yasser and his team. It's been great working with everybody. Thank you.
Yes, sir.
Yes. Yeah, Mazen's already spoken for us. But yeah, it's been a wonderful experience, and we're still here for the next 2 days. We've loved the hospitality. We've learned so much about the system and how we can improve ourselves in multiple ways. So we hope to continue to this exchange of knowledge, of information, and have a long-lasting relationship, not just like a one-time visit. So we're looking forward to keep doing this.
Thank you very much, Dr. Yasser, Dr. Mazen. It was wonderful to have you with us, and we are still having you for next 2 days, so be prepared. This CME wouldn't be possible without our sponsors, MSN. So they have a short presentation, so I'll welcome representative from MSN to have a 2-minute presentation. So welcome.
3 strong clap for Mazen and Yasser.
So, good evening to all of you. So, my name is Satish Bans. I'm representing MSN as a country head in Tanzania. So, MSN is a pharmaceutical company based from India, from Hyderabad, and we are exporting more than 67 or 75 countries. And this is also just small overview for MSN. So, our head office is in Hyderabad. We are the fastest growing in API as well as in FDA first. The finished dose forms, and then we are at the glance that 500 million USD and 6,000 workforce all over the India, and 65 markets, that is 65 market countries, and we have 823 patents and 17 first in a generic all over the world. And these are our portfolio that we have submit our dossiers in the different countries as well as in different nations across the world. So, and we are the fastest growing company in drug in the US as well as in the Latin America and as well as in emerging market in Asia as well as Africa. And this is a global strength of MSN. We are operating all over the world, more than 65 countries. And we are very committed to the quality, and if you will check for the quality products, so we are in the top companies in quality wise. And so these are the special approvals from different drug authorities across the globe, and you can find here TFDA because we are also approved from TFDA. And this is the active pharmaceutical ingredients. So we are believing in research for better medicines, that from small molecule to bigger molecule and single molecule to combination molecules. So we do have 35 therapies so in our portfolio, and this is a finished dose formulation. So 17 first in the world generic and 5th manufacturing facilities all over the world. And in North America we do operating, and first to file 15 more pipelines, drug manufacturing, drug master files. And we are also operating in Europe, and this is emerging market, which is Africa, and then Asia as well as then we are also operating in India. So more than 800 our field forces are there, so across the nation. And this is our main motive, research and development and if you will see that many products, we are the first one in Tanzania who launched like Plarinon, Prasugrel, and then Aronologine, which are very superior in the cardiac and we all know that in the JKCI, and they are very usually prescribe our medicine. And thank you very much for this. And this is a manufacturing our facilities all across the globe. And this, thank you very much. So thank you very much JKCI for the support, and we wish that in upcoming CMA we will also sponsor the same. Thank you very much.
Thank you very much, MSN. So can we have big claps for our presenters? Before we end, I would like to thank all the participants who have attended physically and who are there online. I think we're 350 on Zoom. So thank you very much for coming here, and there are more CMEs to look for at JKCI. So we'll be having over the year, 1 year, next 1 year. And for final words, I would like to welcome our Executive Director, Professor Janabi, so that he can take over and close this meeting. And then dinner will be served outside. So everyone is welcome for dinner after the last words. Thank you.
Yamani, good evening again. The organizers, Dr. Kisengi and Dr. Kuzema, thank you for organizing this. We were on the back just supporting you. I was watching the participants. The total was about 388, apart from we here. And I think this is one of the objectives of our institute. That's why it's called Jakaya Kikwete Cardiac Institute. So there'll be more of such CMEs. We are hoping, if everything goes well, end of March, from 24th to 26th, we are going to have another big one of arrhythmia, and there'll be invited speakers from outside Tanzania. For Dr. Yasir and the team, thank you for excellent presentation. I tried to do a warm-up with heart failure, but when I watched you two presenting, I looked myself as a kindergarten, but I will. I promise you I'll catch up. Otherwise, thank you very much for those who managed to be here physically. And I'm sure of the two main presentations and the introductory of heart failure, you have gained one or two things. The thing to do next now is how is it going to change your practice, your daily practice? But because don't leave everything you had here. I talked about heart failure, how we don't give complete doses to our patients. We have seen technologies of how to manage endocarditis. We have seen how time is important, and sometimes the patient comes with the pain and he's rotating from radiology, chest x-ray, echo, and Mayala will insist on detailed echo, which takes about an hour to finish. So we should try to cut the time so that we can save the muscles. Last but not least, our sponsors, CMN, MSN. Thank you very much, and I hope you'll continue supporting us. Of course, we declare no conflict of interest. We didn't take one of your drugs, so it was a pure support. And last, announcement for all cardiologists, cardiac surgeons, and tomorrow at Protea from 6, we'll have another presentation, and Yasir and the team will go together. There's going to be a presentation of ECMO using post-COVID and ventilation strategies, how to use, because we all know COVID is still here, so kindly. And for our surgeons, there'll be a presentation of how, because now the way we do bypass surgery at our center here, we harvest from the legs and everything, a huge scar, and as you know, the world has changed to minimally invasive. So there'll be an endoscopic vessel harvesting, why and how, and so please try to attend, because 2 of our colleagues will join the course shortly. I think it's William and Alex, I'm not sure yet. So please, let's all of us, those who can, at 6 there, and they promised me dinner will be there, and it's a good dinner, I can tell you. So just come and join. Otherwise, again, thank you everyone, thank you the presenters and our other colleagues, and hope to see you tomorrow to continue with the training for balloon and the complex PCI. So dinner will be served here, but give us 2 minutes. Our guests and Kisengi and Kuzema, if you can go out first, and then we'll call everyone in portions, please. So everyone, the dinner is there for everyone. And Dr. Mlawa, welcome again to the team. And I saw the effect of Zoom. People are trying to be very serious. Jamani, asante. Oh, and before Gary, Amani and the team, it was excellent vision. The pictures were very clear. Asanteni sana na timu yako hii ya wageni hawa, ilikuwa excellent.
Asante sana. Jambo!
Kwa miaka ya hivi karibuni, Tanzania imefanya uwekezaji mkubwa katika sekta ya afya, hususan katika kuboresha hospitali zake kwa kuleta teknolojia za kisasa, kiasi ya kwamba hospitali za Tanzania kama vile taasisi ya moyo Jakaya Kikwete, taasisi ya mifupa Muhimbili, hospitali ya saratani ya Ocean Road, pamoja na hospitali ya taifa ya Muhimbili zinaweza kutoa huduma ambazo awali zilipatikana nje.
And then sisi wanaume tutakwenda tunafuatia. Kwa tunaomba tuwaruhusu tu dada zetu, mama zetu, hapa dada zetu tu. Naomba tafadhali. We have enough food, don't worry about that. In 5 minutes we'll call the rest of the team. Nafasi ndogo ndio maana tunafanya hivyo. Oh, nani jamani, mchukue mgeni wetu Dr. Saw, please. Nani Amani, naomba nisaidie kumpeleka kule kwa upande wa nani wa wageni wale.
Asante sana.
Kwa miaka ya hivi karibuni, Tanzania imefanya uwekezaji mkubwa katika sekta ya afya, hususan katika kuboresha hospitali zake kwa kuleta teknolojia za kisasa, kiasi ya kwamba hospitali za Tanzania kama vile taasisi ya moyo Jakaya Kikwete, taasisi ya mifupa Muhimbili, hospitali ya saratani ya Ocean Road, pamoja na hospitali ya taifa ya Muhimbili zinaweza kutoa huduma ambazo awali zilipatikana nje ya nchi. Uwekezaji huu unachagizwa sana na uwepo wa madaktari bingwa na wataalamu wengine wabobevu wazawa katika huduma za matibabu. Kwa kuwa na mipango na mikakati mizuri ya utalii wa matibabu, Tanzania inaweza kufuata nyayo za mafanikio ya nchi kama India katika sekta ya afya. Hili linatokana na sifa ambazo Tanzania imekuwa nazo hasa katika ukanda wa Afrika Mashariki na Kati. Mojawapo ya sifa hizo ni Tanzania kuzungukwa na nchi nyingine zenye mifumo dhaifu ya matibabu kuliko yenyewe, hivyo kutengeneza uwezekano wa raia wa nchi hizo kuwa watalii wa matibabu hapa nchini. Mbali na hilo, Tanzania imekuwa na sifa kubwa ya amani na utulivu, jambo ambalo linavutia wageni wengi kutembelea nchi yetu, ukizingatia hospitali hizi bobezi zinafikika kwa urahisi, zikiwa na umbali wa wastani wa kilomita 10 kutoka uwanja wa ndege, huku gharama za malazi zikiwa nafuu sana. Ukilinganisha Linganisha na matumizi makubwa ambayo Tanzania imekuwa ikitumia kwa ajili ya matibabu nje ya nchi, ambapo kwa mwaka 2015 Tanzania ilikuwa na bili ya bilioni 554 ya gharama za matibabu ya Watanzania nje ya nchi. Na kisha ukirudi kuitazama nchi jirani ya Kenya, ambayo nayo ni mpya katika utalii wa matibabu, imekuwa ikitengeneza pato la trilioni 2 kwa kila mwaka kupitia sekta hiyo. Lakini ukienda mbele zaidi, mwaka 2013 nchi ya India ilipata shilingi trilioni 6 na kutegemewa kukua kufikia trilioni 18 kufikia mwaka